Hi, my name is Chantel Thomas, and I'm currently a P4 student at Texas Tech University Health Sciences Center in Abilene, Texas. I'm currently in Dallas, Texas with Dr. Shefra McKee at UT Southwestern in the NICU department. And today I will be presenting my in-service presentation titled Buprenorphine Use in Neonatal Abstinence Syndrome. So let's get started. Starting with my learning objectives, we are going to recognize the concept and background of neonatal abstinence syndrome, also known as NAS. I'll be using that interchangeably throughout the presentation. Outline the current standard treatment for NAS. Analyze current trials on emerging treatment for NAS. And at the end, we will be able to provide recommendations on buprenorphine's place in therapy for NAS. So one may ask, what is neonatal abstinence syndrome? So let's give you a little background information on that. Neonatal abstinence syndrome is what happens when a baby is exposed to drugs in uterus before birth. Any medicine that affects the mother's central nervous system can also have an effect on the baby's nervous system in utero. The most common source of neonatal abstinence syndrome is opioid medication use. What happens is that these babies are so used to receiving this drug from the mother that once the drug is no longer available to them, then they'll start having these withdrawal symptoms. And we'll talk about those withdrawal symptoms in just a moment. But as far as those opioid medications go, such as heroin or prescribed medications such as codeine or oxycodone, those are not the only things that can cause neonatal abstinence syndrome. Although it's the most common, it's not the only option. Stimulants such as amphetamines or cocaine, antidepressants such as SSRIs, barbiturates, alcohol, even marijuana, nicotine, smoking, and also alcohol use can also have an effect on the baby, causing neonatal abstinence syndrome. Some background on the prevalence in the U.S. is that opioid use during pregnancy has increased to 333% over a 15-year period, and it continues to rise. The increased prevalence of substance abuse during pregnancy correlates with an increase in NAS incidence. So, like I said before, the baby will have these withdrawal symptoms due to the fact that the drug is no longer available. Those signs and symptoms include trembling, too much crying, high-pitched crying, sleeping problems, poor feeding, yawning, stuffy nose, sneezing, vomiting, diarrhea, excessive sweating, fever, unstable temperatures. You may even see some seizures with it, tight muscle tones, and overactive reflexes. These signs and symptoms often depend on the type of drug that was used, the last time the mother used it, and if the baby is full term or premature. Short acting opioids such as heroin typically show their symptoms within the first 48 to 72 hours after birth. But long acting opioids such as methadone or buprenorphine also presents their symptoms more on the later side of later than 72 hours, but usually within the first 4 days is when you'll see these symptoms. As far as the diagnosis goes, moving forward, healthcare providers use the Finnegan Neonatal Abstinence Scoring System to be used to help diagnose and pinpoint how serious the baby's withdrawal is. The assessment is based on the level of consciousness, neuromuscular control, strength reflexes, complex reflexes, autonomic function, in those seizures that we would see. Also, with the diagnosis, we would often see based off of if the mother had received prenatal care or not. If she didn't, then we would automatically do a toxicology screening on her, or if it was done late, we would also do a toxicology screen on her as well, um, just so that we could see if there's anything in her system. Um, the figure here on the right is known as the Mother Nass scale, and I put this one into the presentation because it's the specific scale that they use for the trial that I'll be talking about. And it's just honestly a modified Finnegan scoring system, but this one ranges from 0 to 42 when the typical range in practice is approximately from 2 to 4. It still gives you the same diagnostics, um, the higher the score, indicating greater severity. So now that we've talked about diagnosis, let's go into the current treatments. The current treatments that we have some non-pharmacological treatments available, which is the environment control, diet, and cuddlers. For environment control, you're going to want to make sure that the baby is in a very quiet place, and that there's no excessive noise. As far as treatment goes, it's only warranted for patients who have 3 NAS scores above 8 or 2 NAS scores above 12, also known as the rule of 24. That's in normal practice. But as far as the clinical trial goes, they start to look at the they look at that mother NAS scale, which they indicate that the threshold for pharmacological treatment was a sum of 3 scores of 24 or more, or a single score of 12 or more. The number one treatment that's mostly used in practice is morphine. It's a short-acting opioid. It's dosed 3 to 4 hours per day. Its dose is 0.04 milligrams per kg per dose, and the max dose is 0.2 milligrams per kg per dose. The length of stay in the hospital, which is very essential in terms of the clinical trial we're going to look at, is about 6 to 42 days. As far as methadone goes, it is a long-acting opioid. It's dosed twice a day, and its dose is from 0.05 to 0.1 mg per kg per dose, and its length of stay in the hospital is 16 to 44 days. There's also an adjuvant therapy, phenobarbital or clonidine, that's used if these treatments have hit their maximum dose and we're still receiving those symptoms. Some advantages of morphine is that there's no alcohol content and it has a short half-life. But the disadvantage is that it has an increased risk of sedation, apnea, constipation, and it's frequently dosed. On the other side, methadone has a long half-life, 12-hour dosing, and its longer duration of treatment is a disadvantage. Alcohol content is about 8%, and there's frequent follow-up needed. Standard length of treatment that you'll see in clinic is about 2 weeks long. Honestly, essentially a minimum of 11 days. Moving on to the emerging treatment, buprenorphine. Buprenorphine is another opioid that we'll see that is being used in the treatment of neonatal abstinence syndrome. As far as this clinical trial goes, we saw in the New England Journal of Medicine, we saw a single site, double-blind, double-dummy study design with a sample size of 63 termed infants. Termed was defined as a baby greater than 37 weeks gestation. The treatment regimen was randomly assigned in a 1-to-1 ratio to receive sublingual buprenorphine versus oral morphine and the corresponding placebos for both of them. The primary endpoint of this trial was the duration of treatment for neonatal withdrawal symptoms in the days from the first dose of a trial drug. Buprenorphine, or its placebo, was administered sublingually every 8 hours by a syringe under the tongue, and they also use a pacifier to be placed in the infant's mouth to maximize the contact within the sublingual mucosa. So that's why I said that with the symptoms of that excessive sucking on the pacifier, that's going to help aid in the baby getting the buprenorphine. As far as the morphine goes, the morphine was administered orally every 4 hours. Moving on to what they did in terms of what were their initial dose as well as the maximum dose that the two could get, was that the maximum dose was 60 micrograms per kg per day for buprenorphine and 1.2 milligrams per kg per day for morphine. As you see, that it was fairly similar across the board in terms of the titration rate. It was about 25% for buprenorphine and 20% for morphine. And as you could see, another difference is that buprenorphine has that ethanol additive in it, and morphine did not. But as far as the results go, the duration of treatment in the buprenorphine group was 15 days compared to 28 days in the morphine group, with a p-value of less than 0.001. And also there were similar side effect safety profiles that were seen in both groups in terms of one being a hernia repair and another one was a supraglottalplasty that was both seen in the buprenorphine group. As far as my final thoughts, neonatal abstinence syndrome is a very socially biased syndrome. And what I mean by that is that there are some mothers that do have to take antidepressants because they are severely undergoing depression at the moment, or that they do, which I learned in rotation, is that some of these moms undergo sickle cell pain crisis, and that they do need these opioids in order for them to withstand the pain that undergoes on their body, and the stress that undergoes on their body. They may need this. And so we can't always think that the reason that these women are taking these opioids is just because, they're just addicted to drugs. No, sometimes it's really what they need in order to maintain their pain that they're going through. The current therapy that we use with morphine and methadone has shown to be beneficial and has great outcomes in treating this syndrome. So I don't steer away from these two. They're really good in practice, but as we all know, medicine is emerging, and we just consider what are the next steps. Buprenorphine is a great candidate for babies who do not have any other medical conditions. And what I mean by that is not having any medical conditions that's going to allow them to stay in the hospital longer than the length of stay that we know to have to treat neonatal abstinence syndrome. So if they're going to be here within those 15 days or so treating the neonatal syndrome, then there's no need for us to be on that medication if that. And then the sublingual administration is just quite difficult for me. It's something that I just can't see really done well in practice, and just seeing how difficult that would be to keep the pacifier in the baby's mouth and just to get that good contact time. Limitations that I saw, and as far as the trial goes, was just the small sample size, and also that it was single-centered design. So with that being said, here are my references. Thank you so much for listening, and I hope you learned a little bit more about neonatal abstinence syndrome. Thank you, and have a great day.